So our next speaker, I think many of us know very well. Luis spoke to us at the very first translational plenary session that we had years ago, but still I went and did my internet search to make sure I had my introduction right. So when I look up Luis Diaz, the first hit is, on August 13, 2005, Luis Diaz was released from Florida prison after serving 25 years for crimes he did not commit. It's important, he did not commit. But currently, he moved from Johns Hopkins several years ago to take on a leadership position at Sloan Kettering, where he is head of the Division of Solid Tumor Oncology. He has been a pioneer both in liquid biopsies as well as immuno-oncology, especially with a seminal paper in the New England Journal of Medicine just a few years ago. And we wanted to have Luis back to give us an update on liquid biopsies. Thank you, Luis, for joining us.
Great. Thanks, Lee, and thanks for the introduction. The one common link between your story with my name and this story is that DNA exonerated that person. I'll be talking about DNA today, but no criminal record.
You know him well.
Yeah. So these are my disclosures. An important slide, I think, going forward for all of us to remember that when we have relationships with industry and academics, we really have to pay close attention to disclosing everything. And these are disclosures for the past 5 years. It's stuck on it. So you get to look at it.
I informed them to do that.
Okay. All right. So I'm going to begin with how does cancer evolve? And what I'm showing here is normal colonic epithelia here in this slide, or this circle here. And in a patient with colon cancer, how that goes from the normal state to a premalignant state to an invasive state to then a metastatic state. But if you look under the hood, histopathologically and molecularly, what you see is the accumulation of histopathologic changes, and genetically you see the accumulation of somatic mutations in key genes that are selected for essentially for a growth advantage. And this happens not over a few weeks, not over a few months, not over 1 year, but rather over decades. And this process is a process that takes time, at least for most garden variety adult tumors. And this is an important concept as we get into some of the themes I'm going to talk about using these mutations for really important biomarkers. There is a concept that I think is really important to drive home as we dive into this, is that these mutations in cancer are highly specific. What's that mean? They're just in the premalignant tumor tissue and the tumor tissue, but not any other cells in the body. And these aren't the hereditary mutations like BRCA that are passed on from generation to generation. They're somatic. They're just in the tumor tissue or the premalignant tissue. And that sets up a scenario that's very potent. Incredibly high specificity in case you have a drug that can target that mutation in the form of a protein and result in an extraordinary result like the PARP inhibitors, or if you want to use the mutation as a biomarker. And I'll be explaining that in the next few slides. So we're really leveraging using mutations as biomarkers from the work really across multiple different tumor types in adults and children, essentially doing sequencing across all these tumor types. And now it is the exception to find a tumor where we don't know the molecular landscape of that individual tumor. We know the genetics of most of these tumor types very well, but what we don't know is what to do with all these mutations. There's maybe a dozen, max a dozen and a half mutations that have a therapy that either has a therapeutic indication that's FDA approved or in process of being studied. Everything else, and there's 2 million mutations out there across 30,000 genes that have been cataloged, we don't know what to do with them. Some of them can be prognostic, as I can show here, what we do with this data. Some of them can be predictive, like you saw with the BRCA mutations that are somatic, or germline that show a very potent anti-tumor response. But those are the rare indications. And in some cases, like track fusions, or even in the case of MSI, you can pick these as biomarkers where you can have a very potent response to a targeted or an immunological therapy. What I'm going to talk about here are liquid biopsies. I'll give you an update of what we've done really over the past decade and a half, what the challenges are, and where we need to go to really make this a robust approach. So what is liquid biopsy? So frankly, liquid biopsy is just drawing blood and looking in the blood. And that could mean looking at a CBC for your red blood cells, white blood cell counts. That can be looking at proteins like the CEA or PSA. But lately, over the past 5 to 10 years, we've talked about looking at using liquid biopsies to look for circulating tumor cells or cell-free DNA. And those are things that are emitted by the tumor cell, in the case of cancer, into the circulation that can be enumerated and used in a variety of different approaches. The problem is that these cells or these fragments of DNA are rare. And while it's easy to draw blood, it's really hard to analyze them, and it's even harder to use them in such a way to make a meaningful clinical impact. And that's really the goal here. So normally when we look for mutations, we look at tumor tissue. And that's why we heard about paired biopsies being so important. We wanted to find changes before and after therapy that might guide us on how to better use that therapy. And that's usually formalin-fixed tissue or frozen tissue. When we start talking about liquid biopsies, we can actually draw blood and sequence that in methods similar but not exactly the same to what we use in tumor tissue to find mutations that might be coming from the tumor. And that might allow us to do a variety of different things. And so if I drew blood from anyone in this room and took the plasma, extracted the DNA, and ran it on a gel, what you would see would be the following. You'd see a ladder that's very reminiscent of the apoptotic DNA ladder when cells are undergoing apoptosis. If someone was having a heart attack or a stroke, and I looked at that same fraction of DNA, you'd see necrosis, which is a different type of death. And that's really releasing larger sheets of DNA into the circulation. So you have two forms of DNA in your blood. In most healthy people, it's this fragmented DNA. And let's say one of you was pregnant and we drew the blood. We could actually see in that blood a mixture of DNA in the circulation from the mother and the fetus. And actually, this has been the first clinical application of cell-free DNA. As little as 6 to 8 weeks, 10 weeks after conception, you can draw the blood, and you can sequence that DNA from the plasma, and you can find inborn genetic alterations in the fetus with very high fidelity. And you can find all kinds of characteristics from that fetus just from a simple blood draw. Likewise, if you had a transplanted tumor tissue, or a transplanted organ, let's say a liver or a kidney, you can draw the blood and look for chimerism, and you can look for evidence of rejection just by looking at the cell-free DNA in the plasma from that individual patient. And if someone has cancer, you can draw blood from that person, and a fraction of that DNA will come from the tumor in that patient. So how do we differentiate the DNA in cancer from normal, coming from all these different tissues in your body, undergoing normal apoptosis, the GI tract, the skin, a variety of other organs like the bone marrow, and the tumor? Well, you just look at the difference between wild-type tumors and mutant DNA. So the mutation gives us the ability, in a very specific manner, to find the fragments of DNA that are coming from the tumor tissue. And how do you address this? This is actually how we began using digital PCR approaches initially. It's an approach where you can look at a single mutation at a time. If you know what you're looking for ahead of time, you can track it in the blood. It's very quick. It's very cheap. You don't need heavy bioinformatics. Lately, we've evolved to next-generation sequencing, and again, technologies that we've developed where you can look at large regions of DNA, many genes, many exons, in fact, even whole exomes, whole genomes, to look for structural changes and multiple mutations, and that's outstanding for discovery. The problem is that it's very expensive, and you have to have a lot of bioinformatic know-how and actually laboratory know-how to reduce the errors so you can actually see mutations in the frequency and the sensitivity that you want. Okay, so that's background. What can we do with these? And we started working on this about 2004, 2005, and at that point we couldn't get things published about cell-free DNA. No one believed it. And this is an example of one thing that you can do with it. You can track. You can measure the burden of tumor. So this is a patient with a melanoma treated with a checkpoint blockade, had a fantastic response, had evidence of pseudoprogression initially, but on the column in the blue, that's a cell-free DNA fraction, and on the left, actually, it was a palpable tumor that responded. the cell-free DNA fraction went negative much faster, but it was a correlation with tumor burden. It was like your PSA or CEA that it would increase with the amount of tumor increasing or decrease with tumor going down. Pretty straightforward. Advanced, maybe a little bit, really doesn't move the needle that much. What else can we do? Well, we wanted to start thinking about applications that weren't possible before. And one of them was, can we track the emergence of resistance, molecular resistance, just by drawing blood, without doing sequential biopsies, and just by sequencing the blood cell-free DNA and looking for mutations that might accumulate. And the model, as we all know, and as you saw before me, is that most targeted therapies, when they work, respond, and then by and large, most of them, especially when they're used as single agents, become resistant. And if we had a model system where we can study this, maybe we could track resistance molecularly just by drawing blood. And these are studies that we did in the late 2000s. And the first model we used was EGFR blockade. At this point, we had no idea how EGFR blockade acquired resistance developed. But we knew at this point that you had to be wild type for KRAS, and if you were wild type for KRAS, you had a 17% chance of response. And by and large, we had a sense what genes and mutations might be involved in acquired resistance. And so what we saw is we drew blood in these patients longitudinally while they were getting anti-EGFR therapy. And this is an example of one patient who responded and then progressed. Same time, anti-EGFR therapy, and we saw the patient go from wild type to KRAS mutant, and we saw the patient go from wild type and KRAS to multiple KRAS mutations. And then in another publication, we began to look at multiple genes, and we saw patients who were wild type in KRAS and NRAS and BRAF and EGFR go from wild type in all those genes to mutant in not just one gene, but multiple genes, and in multiple alleles in the same gene. So we proved that we could track resistance, and in this case, we actually discovered a resistance mechanism for EGFR blockade. And we could look at the EGFR pathway, and we actually found that the resistance tracked down one arm of that pathway and not the other, so more towards the RAS-RAF pathway and less on the PAKT, PTEN pathway. But it also taught us something from a therapeutic standpoint that we all know, but it's hard to look at. We know how to treat the pan-wild type patient with EGFR blockade. We have no idea how to treat the patient with multiple tumors, multiple mutations in multiple different clones that will likely require multiple different drugs. So one thought is maybe targeted therapy is going to fail in most cases as a fait accompli. Maybe these resistant mutations, which in this paper we found were pre-existing, just are going to grow up no matter what. And it's just a matter of time. What I think we're learning is that the truth is somewhere in the middle. But targeted therapy does lead us to a situation where we have multiple resistance pathways in that same patient. So we are creating a more complex patient, especially when we treat with monotherapy. So that was tracking resistance, and that was great because it allowed us to understand the biology of our therapies and maybe even change therapy in the midst of treatment to a more potent impact. But where could we really go where we can have an even bigger impact? And this is the concept of minimal residual disease. And this is a concept that medical oncologists know very well. And the patients are being treated with definitive therapy, typically by surgery, excellent surgeons, and the surgeon always says, I got it all, you're cured. And then they come to your clinic, and you have to explain to the patient, they always say that, you're gonna have to get therapy for 5 years, and then we won't know for maybe another 5 to 10 years. And so you cannot define who's cured or who's not after the surgery. Sure, you have a visible R0 resection that's microscopically confirmed, but all you have at that point is the staging system to give you an odds of whether you're going to recur or not. And we do a lot of treatment decisions by that. And in some diseases like breast cancer, we have that same tissue, and there's expression analysis tests that will give us a more refined risk profile, but it's not perfect. But what if we could flip things and measure the patient after surgery to see if there was any remnant minimal residual disease? Is there any disease left in the body? And can we use, let's say, this technology to answer that question? And so there have been other approaches looking at minimal residual disease, but many have been hampered by lack of sensitivity. PET scans, CT scans, protein biomarkers, even CTCs, not sensitive enough or too sensitive really for this application. So we wanted to see how cell-free DNA could be used in this setting. And this is really the first case where we saw that just maybe it might work. Colorectal cancer patient undergoing definitive curative therapy. And this patient had a mutation of APC in the tumor that was resected. This quadrant here in the red are the mutant fragments in that patient's blood. The ones in the green are the wild-type fragments. 1 day after surgery, post-op, we draw blood. We measured circulating tumor DNA, the same APC mutation that's in the tumor. It's almost all gone, 0.015%. Day 42. CT scan's negative. That's when they see the medical oncologist, and we have to say we're going to give you chemotherapy. There was an increase in circulating tumor DNA. And at that point, the patient had a chance of being cured. We had no idea if they were cured or not. And by day 244, the CT scan was negative, and there was an increase in circulating tumor DNA. We knew there was remnant circulating tumor DNA in that patient's body at day 1. And it shouldn't be there, because these fragments have a half-life of about 2 hours. So in about 10 hours after surgery, it should be all gone, or undetectable, essentially. So we could actually tell 1 day after surgery that this patient was probably going to recur. But this was one patient. So then we looked at more patients, and we used a typical biomarker for colon cancer, CEA, and measured at 6 to 8 weeks after surgery. And those with detectable CEA levels all recurred. And those with undetectable level, some recurred and some didn't. And this is a statistically significant difference, but that's not a clinically satisfying slide. Sure, you get a little bit of improvement, but if you're a patient, you're going to be nervous on either one of those curves. But when we looked at circulating tumor DNA in the small pilot group, the patients with detectable circulating tumor DNA virtually all recurred, and the undetectable patients did not. Again, a pilot study, but subsequently we worked with our colleagues in Australia, G&T and Peter Gibbs, to look at stage 2 colorectal cancer patients, 250 patients, resected tumor tissue, sequenced for well-known colorectal cancer genes, found those mutations, and at 4 to 10 weeks after surgery, measured the blood for those exact same mutations. And what we found was the following, that the pictures look very similar. If you were positive, the positive predictive value for recurrence was about 95%. If you were negative, it was less. But in all subsequent studies that have now been done in pancreas cancer, neuroblastoma, lung cancer, lymphoma, and breast cancer, the positive predictive value of being circulating tumor DNA positive for a mutation that was in the resected tumor, and that's what gives it the power, the identity of those two mutations being identical, the positive predictive value for recurrence is above 90%. So it gives a scenario that this just might be a very potent measure of minimal residual disease that we can actually use for clinical decision making. And what we're really excited about is using this as a methodology to begin to do rational drug development in the adjuvant setting, which hasn't really been possible. Because as we all know, most adjuvant studies take all comers. A good chunk of those patients were cured by surgery alone, and they're not enriched for the worst actors there. And using this technology, we can enrich for a population that is enriched for a likelihood of 90% or greater of recurring, so the sample size goes much smaller, and you can look at endpoints in a much more defined cohort of patients, and hopefully dose intensify, therapy intensify, rather than give probably an attenuated chemotherapeutic regimen or adjuvant regimen that is supposed to both treat cured and non-cured patients from surgery. So that was minimal residual disease. But what would be the real home run of this technology? The real home run to us would be early detection. Can we catch tumors when they are at the point where they have a 95% chance of cure by surgery or some other methodology? So this is a survey that we did a few years back where we looked at almost 700 different tumors from different tumor types across all the different stages. Now, we didn't go in blind here. We wanted to see what the best possible outcome could be. So we sequenced these tumors after they were resected, but we drew blood before they were resected. And what we found was that even in stage 1 cancers, we could detect about 42% of patients. And you see on the other panel the range or the amount of mutant DNA in those samples. So there's a wide range. But what gave us hope here is, while we wanted to be as high as 90 or 80 to 90% in terms of sensitivity, we could still detect a large number of stage 1 and 2 patients where we could potentially have a very high chance of cure. What really drove it home for me that this might be a viable opportunity for early detection was actually going back to looking at pregnant individuals who were getting these tests looking for chromosomal abnormalities in the fetus. And there began to be emergence of cases where there were changes in the chromosomal pattern that were not consistent with something going on in the fetus, rather something going on in the individual pregnant female. And those changes persisted after the healthy, genetically normal baby born. And in this case, this was a healthy, otherwise unbeknownst individual with no cancer, with abnormalities consistent with a somatic change in some sets of clonal expansion of the body that persisted, and this patient had stage 2A Hodgkin's disease. Another report in 400,000 women, 38 cases, same scenario. Aneuploidies or changes in the genomes noticed in the circulating cell-free DNA that were not consistent with changes in the fetus, and these individuals had clonal expansion, most of them malignant, but some of them benign. So this, to me, gave me the hope that cell-free DNA can be used for early detection, because these people weren't looking for it. They found these incidentally or by accident, and they were really finding serious cancers in these patients at a very, very early stage. So what about other ways to detect cancer early? Same technology as we use in the blood, you can look at in the saliva, and we did a study in head and neck cancers where we look at causative agents like HPV plus mutations. And as you can imagine, because the saliva bathes many of these tumors in the oral pharynx, in the hypopharynx, you can detect these cancers with very high sensitivity and specificity. And in a study that we did a number of years ago now, we had a hypothesis that cells and fragments of DNA would be shed into the fallopian tube and into the uterus and lodge in the cervix, and then a simple pap smear brush would collect those cells and fragments of DNA. We could extract the DNA, sequence it, and that would tell us if there was a tumor in the GYN tract. And what we found, again, using the same technology, the next generation sequencing technology that we use in the blood, that we could take DNA from a simple pap smear and detect 100% of endometrial cancers, and whether they were stage 1A or even stage 4, and that makes sense because it's anatomically so proximal to the cervix. But what surprised us is that we could detect 40% of ovarian cancers, and even at the earliest stages. So an opportunity for early detection where there currently aren't any screening strategies. So when we look at the current state of studies, and these are preliminary studies, these are not large population studies, these are proof of principle studies, and we look at a variety of different bodily fluids, not just blood. When we look at stool, urine, blood, pap smears, and saliva, and we emphasize the tumor types that we are trying to detect, and we talk about the source of DNA, whether it's cells, whether it's cell-free DNA, or maybe it's a mixture of cell-free DNA and tumor cells. I've listed the sensitivities, what the current studies are showing for stage 1 and 2 disease. The stages where cure is most likely or above 80% in most cases. So with stool, we can detect more than 50% of colon cancers. With urine now, we can detect about 80% or more of bladder cancers. In the blood, stage 1 and 2, we can detect about 60% of cancers. Pap smears for endometrial cancers are outstanding, and ovarian cancers currently, we're about 30 to 40%, and in saliva, greater than 80% of head and neck cancers. So just detailing what the future might look like, where we can sample multiple body fluids at regular intervals to enrich for those people who may have occult malignancy that we can't detect. So I've painted a rosy picture, but what are the challenges? Well, the first is that I lied to you. So I told you that mutations are highly specific, right? And that they're in the pre-malignant or the malignant tumors and not in the normal cells. The problem is that's not true. The body has tricked us, and we've learned this because we developed sensitive techniques to begin to find mutations that were very rare levels. And what we found in the process, along with other population-based studies, that in this case, for instance, the bone marrow can achieve what's called clonal hematopoiesis. So it accumulates mutations, it gives a clump of bone marrow cells more likely or better fitness to survive in that cell, and you can actually detect these mutations. Interestingly, when those levels of occult blood cells are very high, you have a high risk of leukemias, and in some cases, actually, you have a high risk of cardiovascular disease, and we don't know why. And so that's something that's ongoing. And we know these events called clonal hematopoiesis increase with age. There's another problem, that this just doesn't happen in the bone marrow. And we were involved in the study with endometriosis, like I said, clonal hematopoiesis, and even aneurysms. And we are finding somatic mutations, even in endometriosis, that have KRAS mutations or PI3 kinase mutations. The clonal hematopoiesis, you have mutations in genes that, for all intents and purposes, look like leukemia. And you have TGF-beta receptor mutations in aneurysms. So not all mutations that you find are going to be cancer. They might be associated with other benign clonal expansions, and that's something that's going to get in the way of using these things for early detection. The second is localization. This is a gentleman who came to me from China, terrified. They had found a KRAS mutation in his blood. Somebody was doing this testing locally there, and they found this KRAS mutation. He'd gotten a CT scan, PET scan, colonoscopy, PSA is all normal. Obviously, we couldn't even know where to look for this mutation. This is a mutation that's found in lung cancer and pancreatic cancer, colon cancer. And so where would it be? Where would you go look for a cancer like that? And so that's a big issue, localization. In this case, we repeated the test. It was negative. It was a false positive. Another barrier I'm not going to talk about is the technical issues. There's a lot of limitations there. Other issues, heterogeneity. Different tumor types excrete different levels of cell-free DNA. And so different tumor types will have different levels of sensitivity. And then finally, there's biological limitations. There's just not a lot of mutant molecules in the blood. There's about 1 to 3,000 genome equivalents per ml. You need at least 3 to call a positive result, and the sensitivities are limited by insufficient mutant molecules. So you're not going to develop a better test, a more sensitive test, that's going to overcome that. The molecules just aren't there. And so that's one thing that I see as we begin to commercialize this, that people are saying, oh, we have a sensitivity of this, this, and this. There's still that biological limitation. So challenges, not all clonal events are cancer, heterogeneity, localization, very few molecules in the blood. We want to focus on unmet clinical needs. There's few targeted therapeutics, and currently the costs don't match the clinical benefits. I think we really have to focus on early stage disease, minimal residual disease as well. There'll be incremental improvements in ctDNA technology, use of comprehensive panels, limited by biology more than technology. We need a biological-based discovery to drive dramatic improvements in our ability to detect things. I right now have about 5 or 6 cancer patients on treadmills trying to get the levels of cell-free DNA up, hopefully by exercise. But we have a variety of different approaches that we're trying. Clinical applications have to be in high-impact applications that, much like drug development, really strive for survival benefits, and in partnership with the FDA and other regulatory bodies, I think they'll be important. So I'm going to stop there. I went a little over, but thank you for being patient. And a lot of this work was done at Johns Hopkins. I recently moved to Memorial Sloan Kettering about 18 months ago, and it's been great. But my original home at Hopkins was great too, so thank you very much.